So how are your Asian Americans and Indian American subset doing with this ablation?
I have no Asian Americans or Indian Americans in my practice. I live in Pittsburgh. Pittsburgh's 99.9% Caucasian and 0.2% others. So I've never seen an Asian American or even Asians, even black Americans, black African Americans, we don't see much it's all white Americans. I haven't seen any Asian Americans. So I really cannot answer that question. I'll leave it to the electrophysiologists here to answer that question. But I don't suspect the left atrial size should vary by race. Right? I mean, I think the left atrium and the pulmonary veins, I don't think there's any genetic difference in left atriums or left size of left atrial appendages by race. I mean, there is some gender variation, but I don't think there's a racial variation in left atrium. I'm sure if there is, we haven't looked into it, but as far as I know right now, there is no racial variation. So I suspect that the data I'm presenting will hold true in India also. Yeah.
Thank you, sir. So regarding the obese AF patients, I mean, because if they are morbidly obese with frequent AF, they are not really going to exercise or reduce the weight. So in those cases, do you offer AF as the first line and then the weight reduction strategies later, or how do you manage these patients?
It's a good question, right? So I offer AFib ablation as first line for paroxysmal atrial fibrillation patients. Keeping in mind that obesity and sleep apnea are independent risk factors, I also look at the left atrial size. So if a person who's obese, well, the question is, who's skinny in the US anymore? Right? Yesterday they were saying BMF 25 is obese in India. Their BMF 25 is normal. My size, my shirt size in the US is medium. Here it's double XL. Right? But obesity, it's very hard to turn people down because of obesity. But the patients will tell you, we swear we'll lose weight if you put us in sinuses. Because we are in atrial fibrillation, we are short of breath, we cannot work out. So it's a double-edged sword, but lifestyle modification definitely has to be a part of atrial fibrillation management. I can ablate their AFib, but if they don't lose weight, if they don't do lifestyle, over 200 pounds, over 100 kilos, we should not do an AFib ablation. Then we went to 110, then we went to 120. Now, last week I ablated a 330 pound, that's a 160 kilo guy in AFib, but he was sinus, he swears, and I told him, look, this is not going to work. He's like, I want to try it. This was 2 months ago. He's maintaining sinus for 2 months now, and he says he feels the best he's ever been. Now, you can argue it's placebo effect, but he's definitely feeling much better because heart failure has decreased. So we have not been turning people down because of obesity, because our goal is to maintain sinus, but we do lay out expectations what your success rate of maintenance of sinus is, right? There are obviously some people, I have a 45-year-old who's 500 pounds, that's 280 kilos. I'm not even going to, do any ablations on him because maintenance sinus, number one, I won't be able to get in to do the ablation, but also morbidly obese. So we send them to bariatric surgery. But bariatric surgery also, they run through 12 months of weight loss, and we see how they maintain sinus rhythm. But obesity is one of the biggest independent risk factors for atrial fibrillation. I think over time it will probably become one of the contributing side effects, because I think obesity is a pandemic in the whole world, right? So it's going to be a problem in the future.
Thank you, sir.
In the subset of patients with the permanent or persistent AF, sir, what percentage of your ablation patients get a success?
No, that's also a very nice question. So people who have permanent AF, maintenance of sinus rhythm I can achieve around 85 to 90%, but I have to maintain them on some drug therapy. I use a lot of, so the two drugs post-ablation which work very well are flecainide as well as dofetilide, because they decrease the refractory period as well as the conduction velocity. So because of that, we can maintain them in sinus for a longer time. So people who have persistent atrial fibrillation, interestingly, a lot of the persistent AFibs have higher CHRS score. But if they have a low CHRS score, they have independent risk factors like obesity or They have risk factors like sleep apnea. So they do have adjunctive disease process which prevent them from maintaining sinus. So what I do now is I'll bring the patient into the hospital. I'll do the pulmonary and isolation. And these are the permanent AFs who haven't been converted to sinus rhythm before. So then I'll do the pulmonary and isolation. And then usually after I do a PVI, I cardiovert them and they convert to sinus rhythm. Once they convert to sinus rhythm, I admit in the hospital for 3 days of Ticosin therapy because we have Ticosin available in the US. If not, I'll send them home on amiodarone therapy. And then I maintain them in sinus. And 90% of the permanent AFs, I put in an implantable loop recorder. And we monitor the AFib with an ILR. You can use an external loop recorder. Nowadays, a lot of wearable devices are coming out. I think there was one called Sankat, which I just saw in India too. People are or Apple Watches. A lot of people are following their atrial fibrillation Apple Watches or smart watches. So we monitor them. We've been reasonably good. Around 85 to 90% of them have maintained sinus rhythm.
Thank you.
First question is, do you have any time frame as to when you will implant a loop recorder after you ablate?
So my partner implants a loop recorder the day he ablates. I don't believe in implanting a loop recorder the day we ablate because there's a 90-day blanking period after an ablation because you can have atrial arrhythmias in 90 days, which we don't have to worry about. Even though, so I usually bring them back in 90 days, and a lot of the insurance companies don't pay for AFib ablation. They pay, but hospital profitability goes down, so I wait 90 days. Or I put in a loop recorder before, and then I admit them for Dofetilide, maintain sinus rhythm, and bring them back for an AFib ablation. But either I'll put it in 3 months before, and then I monitor them. Depending, if I see them, depending on what stage of AFib I see them, but we are using a lot of ILRs for AFib management. And the ILRs last 3 to 5 years, so it gives us a nice time frame where we can assess these patients.
My second question is, in this subset where permanent AF you ablate, do you ever have to combine pulmonary isolation along with posterior wall ablation as a combined procedure? Will that give any benefit, or just do the pulmonary vein isolation and wait for the recurrence?
Oh, that's actually a very good question. So the data has, over the last few years, has said that pulmonary isolation is equal to posterior wall isolation plus pulmonary isolation. So first line, they don't recommend that you do posterior wall isolation, but there are certain subset of people, we will do a posterior wall isolation at the same time, especially if they're in permanent AFib. If somebody who hasn't converted to sinus, so if I do a PVI and I cardiovert them in the lab, but they don't convert to sinus, then I will do a posterior wall isolation. I'll continue and do a posterior wall isolation, and a lot of them do convert to sinus at that time. The other thing is when I do a left atrial, when I go transeptal, I create a 3D map of the left atrium, and if I see a lot of fibrosis in the posterior wall, then I will do a posterior wall isolation at the same time. Now, if I do a 3D map, even though they're persistent, but the left posterior wall appears to be healthy tissue, then we don't want to ablate healthy tissue, then we only do pulmonary isolation. Then I do what you call the wide area circumferential ablation, get a little more of the carina and the antrum, and then we cardiovert them and put them in sinus and admit them for antiarrhythmics. The other thing I've done is, cardioversion, we can do 360 joules. In the obese patients, I put 2 pairs and I cardiovert at 720 joules also. And that usually works. But we have general anesthesia. So I've done that 720 technique, which is not recommended, but we do it in a lot of our morbidly obese patients because when you put the patches on, we have to put the cardioversion patches on. So I've done the 720 joules and it usually works.
Yeah, it's interesting. How do you do the 720 joules?
We just put one anterior posterior, one below, one back, and just cardiovert them. So
okay. Good. Nice actually. Yeah. Thank you.
Do you all recommend any cardiac MRI to assess the LA size and fibrosis or anything? And how will you differentiate any PV and non-PV triggers clinically, or any methods you all have, sir, to do that?
So 6-7 years ago, they did a study and they looked at what you call the Utah scoring scale. The Utah scoring scale was basically you do a cardiac MRI in these patients and you looked at the amount of fibrosis the patient had. If they had less than 5% fibrosis in the left atrium, success rate of an ablation was higher. If they had greater than 20%, which is a Utah score of 4, the success rate of maintaining sinus rhythm was low. But over time, the data really, with ablative therapies getting better, the data has not held the stood the test of time. So people have stopped doing cardiac MRIs to look at left atrial scar or fibrosis. But the greatest predictor of success of atrial fibrillation ablations or maintenance of sinus for any reason is the left atrial size. So that an echocardiogram can really tell you what the left atrial size is. And the interesting part is if I see a patient the left atrial size of 5.6, 5.7, I maintain sinus for 6 months to a year, we notice that the left atrium actually shrinks. It may not go to normal, but it does shrink back to size. So that's been key. So we have not done any scar tissue monitoring, and I think most people, and insurances also have stopped paying for cardiac MRIs for the left atrium.
Any difference in this between this pulse field ablation and this one? Any?
So pulse field is like Dr. Roshan said, is the new kid on the block. We have no experience with pulse field because it's still part of the research protocol. So from when I talk to the researchers, I mean, there are 3 companies coming out with pulse field. One's Boston Scientific, one's Medtronic, and then one is Biosense Webster. They're all coming at pulse field. Pulse field is a new energy source. None of us understand it. But also each of these 3 companies, their pulse field algorithm is separate. We don't know what the algorithms are and how much dose they're delivering. So we really don't, I mean, what we are understanding is that instead of giving 3 minutes of ablation time, within 20 seconds you can isolate a pulmonary vein. But since the data is now out, we don't know what the risk factors are, what pulse field does as an adjunctive, what adjunctive tissues are going to be damaged. We don't know any of that stuff. So we're all eagerly waiting, but everybody we talk to, they're saying it's looking good. But until the data comes out, until we test it in real life, I think adoption is going to take some time. But I think the centers who are doing pulse field, they will be offered it first. I think within a year or 2, those questions are going to be answered. Yeah.
Thank you, sir.
Sir, you have given a list of the criteria where the success is most of the age, etc. you have given. Paroxysmal atrial fibrillation is the number 1. The first episode, or you wait for what kind of, when do you intervene? Paroxysmal atrial fibrillation, and what modality you use to find out the paroxysmal atrial fibrillation. What I'm saying is the first episode itself, the patient goes for ablation, that is one thing. Another thing, after cryoablation, is there a report of any stenosis of the vein?
So good question. So the question is, if it's a 50-year-old person who comes to AFib for one day and gets IV dose of cardizem or beta blocker and they convert to sinus, I usually don't offer ablations to them because if they're low CHAD score, they will have AFib again in a year or 2, but I'm a little more conservative. My thought process is when I ablate AFib, if they have to be cardioverted in the, if they get a cardioversion, then I use that. If they get cardioverted in the hospital and they're sent home on medications, then I kind of offer it to them. But my partners will offer it to everybody. But it's up to the patient to choose or not. As as a physician, we have to tell them these are the options that are available. Some may choose to say, well, I want to get it done, and I would caution them, we don't know if your AFib is going to come back. But if you have 2 AFib episodes in a year, then we will definitely say get an AFib ablation. I have an orthopedic surgeon, I'm doing an AFib ablation on Wednesday. He has AFib once a year, but every time he has AFib, he's in the OR, and then he gets hypotensive, bradycardic, and then he has to leave surgery. Then he comes to the lab, we cardiovert him, then he goes back and finishes his surgery. The last 5 years, I've told him get an AFib ablation, but now he's saying it's getting worse. So then we'll do an ablation on him. But somebody like that, I would offer him first line, just get an ablation done. So it all depends on the patient also. Now, if you have a pilot, who has an AFib episode, okay, so him I would offer it first line. And if you have a physician, who's symptomatic, so it all depends on how bad the symptoms are and what social situation you are in. If you're a cricket player, right, and you're losing to Pakistan, then I'll ablate you. So.
The second part was the stenosis. Does it cause stenosis,
Yeah,
cryoablation,
so
or any other complications of this procedure? Because we have seen all the good points. There must be something behind which we are not exposed to.
So that's my second talk. I'm talking about complication rates. But just to recap, in 8 years, incidence of pulmonary stenosis with cryoablations is 0. So
That's
but
fantastic.
the other complications, they have phrenic nerve injury, and that's my second part, complications.
Is the puncture higher or lower, like comparing to the mitral balloon, which we do?
So with cryo, we always try to go anterior and inferior. Our puncture for transeptal is anterior inferior, because if you are inferior, we experienced that yesterday, to get in the inferior veins is much easier if you go anterior inferior. If you go higher, you can still ablate, but to go into the right inferior pulmonary vein, it's much harder. So we try to keep the stick lower. But if your left atrium size is 6.5, it doesn't matter where the puncture is. In a normal left atrium, you have to make sure you're lower.
Thank you, sir.
What about ablation in patients with reversible causes of atrial fibrillation, say hyperthyroidism, where he is on neomercazole, having atrial fibrillation? You will still give him an option of ablation?
I'm very scared of but no, we don't. Again, you have to be symptomatic, and we have to have ruled out. If a person is hyperthyroid, I very rarely offer them an ablation. If the patient has, adrenal disease, patient has, bad renal failure, right? If the patient has metabolic syndrome, he keeps coming with an insulin of 400, an ablation is not going to work in these patients. We will say, do medical therapy, correct your comorbidities. Dialysis patient, have we taken a dialysis patient with fibrillation? Yes, but then it's not first line. It's just to prevent them from keeping them out of the hospital. So these then become third line, fourth line. I can ablate anybody. We can do an ablation. The question is, will it work? In somebody with hypothyroidism, there's no reason. Before, we used to not do AFib ablations in people with hypertrophic cardiomyopathy. But then the last 2 months, we had a patient with apical hypertrophic cardiomyopathy who goes into atrial fibrillation, heart rate's 150, 160. Hypotensive, gets more symptomatic. And this person, we have never done an AFib ablation to cure him of AFib, but we're doing an AFib ablation to keep him in sinus so we can Bedi him, slow him down. So it also, every time we do a procedure, it all depends on the patient also,
Any questions from the audience?
Some things for particular for the Indian subcontinent actually. What do you think, how would this therapy feature in rheumatic AF? 3 subsets: rheumatic AF untreated, rheumatic AF treated with a valvular intervention or a valvular surgery, and third part is valvular heart disease, like a mitral valve collapse with significant mitral dilatation with AF. In these 3 subsets, how would cryo or any of the ablation therapies work?
No, that's an excellent point, right? Because we have to tailor to the needs of the patients here. So rheumatic fever, I don't know what the data is in atrial fibrillation rheumatic fever, because most of the data we present is in non-valvular atrial fibrillation. Same thing applies to NOACs and DOACs. Everything we use is a non-valvular atrial fibrillation. The question with rheumatic fever, if you put it as a disease state, I'm sure that there is more left atrial fibrosis in this patient population. So isolating the posterior wall definitely is not going to work in these patients. If you have to maintain sinus rhythm, I suspect pulmonary vein isolation will work. To maintain how long it's going to be effective, we have no clue. I know when I was at AIG, they have 15 or 20 patients with rheumatic fever, and the rheumatic fever patients who have mitral valve disease, they say, no, we've done a mitral valve repair in these patients. The question is, will the AFib ablation work? I do not know what the data, none of us know what the data is, but that's something that we could study in India, because there's rheumatic fever here. In the Western world, there's no rheumatic fever. But the third part of it is, have we done AFib ablations in people with post-mitral valve repairs? Yes, we have. We've also done AFib ablation in people who had MACE procedures. We had assumed that if people have MACE procedure, their AFib is, they've ablated everything. Every MACE patient I've gone in, and I've gone into the pulmonary veins, all the veins are open, because during MACE procedure, they don't isolate the pulmonary veins. They go into the posterior wall and they create lines of scar lines to prevent re-entry. but never have they gone into the posterior wall to ablate it. So the posterior wall, the pulmonary veins are almost always open. So now when we send the patients to, if we send them for mitral valve, we tell the cardiologist, the surgeons to do surgical maze, but we also tell them to use the clamp, the AtriCure clamp, so they isolate the pulmonary veins. Even then, 50 to 60% of the time, the pulmonary veins are open. So we have been going into the people with artificial, not bioprosthetic aortic valves, as well as mitral valve repairs to do pulmonary isolation to maintain sinus rhythm. But the patient selection is very careful. They have to be younger. They have to be symptomatic. We don't take them, but in them it will be more like a third line treatment. But we have been taking. I have not done any mechanical AVRs because the balloon may get, the chi wire could be stuck. But at the Cleveland Clinic, we do send people, and even their study, they've done 20 patients with mechanical AVRs, and they do fine with atrial fibrillation ablations. The goal, 5 years ago, so what are our options, right? Even if it's a salvage therapy, would you put a pacemaker and do an AVJ ablation in these patients? Would you do a conduction system pacing, do an AVJ ablation? Would you CRTP and AVJ ablation? So before we offer pacer dependency, I think it's reasonable to try PVI plus medications to maintain the sinus. And most people are willing to try that. And again, like I said, as expectations, if I see a 65-year-old, I'll say, look, I'll keep you in sinus for 3 to 4 years. At 70, get a pacemaker. Or if you're, at 70, maybe you see a rheumatic fever patient, we can keep them in sinus for 3 years. After that, go to Sabrimalai, do your, go for your tour and come back. But it's all expectations what we have to set, and some people are not willing to do it. But I don't know what the data is on rheumatic fever. You probably have more data on that.
One more thing, when you say LA size is a cutoff in all these cases, there's definitely a component of atrial myopathy happening. So that, as you said, most of these atrials shrink after the ablation once you maintain them in size. Is there some way to predict actually, because when you say that a 50 LA is would be a cutoff, if he has been in AF, recent onset AF, you can sometimes do an ablation, they really find that LA is coming down actually. So would the LA size be a really criteria? How can you rule out or rule in atrial myopathy along with this?
No, the left atrial size has never been a criteria for me to refuse ablation. The LA size has only been a criteria for me to predict success rate. But now if you have an LA size of 6.5 to 7, then I'm going to say, no, it's not possible. If your left atrium is twice the size of your left ventricle, an ablation is not going to work. So I use LA size for prediction of maintenance of sinus, not for offering the procedure. Because your point is well taken, the left atrial size is, again, if I keep you in sinus, it's going to shrink. And if it doesn't shrink, then you may not maintain sinus for a long time. But I haven't refused people for atrial fibrillation ablations for a size of 5.5, 6. We do the ablation, and then we have had good success, right?
Thank you. Just one final one. Do you find any role for non-AFib use for these cryo balloons, like for SVC tachycardias or appendage tachycardias, primarily for EP collates actually? Any non-AF use for the cryo balloon?
There's no recommendation to use it for left atrial appendage ablation. I don't even know if anybody is doing that for off-label use. There may be one or two who are doing it. But for SVTs, there's no role for balloon therapy, but they do have a freezer catheter that you can use.
For the SVC tachycardias, if you want to isolate the SVC.
Yeah, I have in the left atrium or?
SVC.
Oh, SVC, I don't have any experience with SVC tachycardia with the balloon. I know some people have done the SVC tachycardia with the balloon. I just use the RF catheter and do that. Thank you. Thank you very much.